Good afternoon. My name is Carolee Lee, and I'm the founder and CEO of WHAM, Women's Health Access Matters, a 501c3 focused on the economic impact of accelerating funding for research and business investment in women's health. June 2023 will mark the 30th anniversary of the NIH Revitalization Act of 1993 that mandated women and minorities be included in all clinical trials and research funded by the NIH. At that time, it took a committed bipartisan group of legislators who collaborated with many different constituents, including patients, providers, advocates, and policymakers, to develop and approve this momentous event. But we still have a long way to go. And WHAM is determined to build a new dialogue and platform to shift these imbalances which still exist. Even though progress has been made, accelerating women's health research and investment is an economic imperative that offers returns for very small amounts of investments. This roundtable will offer the historical perspective of the act that was passed in 1993, where we are today in reaching its mandates, and where we think we need to be to improve the health of women and society. Joining me today are exceptional leaders in their fields. Dr. Janine Clayton, the current NIH Associate Director for Research on Women's Health and the Director of the Office of Research on Women's Health. Dr. Marjorie Jenkins, Dean of the University of South Carolina School of Medicine at Greenville and Chief Academic Officer for Prisma Health-Upstate. Dr. Hadine Joffe, Executive Director of the Mary Harrigan Connors Center for Women's Health and Gender Biology at Brigham and Women's Hospital at Harvard Medical School, and I might say our lead scientific partner. And Jenny LeRae, Vice President of Strategy and Communications at Research America and former Chief of Staff to Senator Barbara Mikulski. I am so grateful that all of you could join me today, and the dialogue will be followed by audience Q&A, so please post your questions in the Q&A section below, and we'll do our very best to answer them all. So let's begin with a brief history of how this act came about, how it was driven by a small group of determined and passionate women, what its objectives were, what the status of where we are is today, and where do we need to be in the next 3 years, not 30. So let me start by introducing Jenny, who early in her career served as Chief of Staff to Barbara Mikulski and had a front row seat in watching this all unfold. Jenny, can you share with us, in your opinion, who is responsible for driving this movement, and how did Senator Mikulski and the others get this pushed through?
Thanks, Carolee. I'm delighted to be here. First, I'm going to look at a few factors that I think are really important in shaping the political and social context of that time, the time in the early 90s, when women's health really first became a federal priority. I'll share some legislative history about the NIH Revitalization Act, which included the requirement for women and minorities to be included in federally funded clinical trials. And then last, but certainly not least, we'll hear about the act and what led to it from its author, Senator Barbara Mikulski, in a short clip. So what was going on in the early 1990s that made it a fertile time for women's health to become a federal priority? Women's health advocacy groups were inspired by the AIDS movement. So one group in particular, the National Breast Cancer Coalition, used grassroots tactics to bring women's health inequities to Washington, and they were extremely effective. In addition, Title IX, which had been enacted 2 decades earlier, was finally leading to a big increase in women in medical school. Title IX, as I think most of you know, prohibited discrimination in education. These women, physicians and scientists, became another powerful force for change, along with the women's health advocates. Lastly, an influx of women were elected to Congress in 1992. Some were propelled by the all-male Judiciary Committee grilling of Anita Hill during the confirmation hearings for Clarence Thomas. The hearings actually compelled some women, like Senator Patty Murray, to run for office. In the 1992 elections, the Senate went from 4 women to 7, and the House went from 23 women to 47. So even though they still constituted a small fraction of their respective chambers, critical mass, as has been shown time and time again, does not require very many women, very many motivated women to reach critical mass and make a difference. And that's exactly what occurred after that election. Senator Mikulski was thrilled to be joined by her new women colleagues, but she wasn't particularly fond of the moniker Year of the Women, which the media gave to the 1992 election. She said, in fact, calling 1992 the Year of the Women makes it sound like the year of the caribou or the year of the asparagus. We're not a fad, a fancy, or a year. The 92 elections also meant that minimal to no representation by women on key health committees like appropriations and energy and commerce could now finally begin to change. And at the same time, it was becoming clear that legislation was needed to force NIH to require women and minorities in clinical trials. There were internal regs on the books, but a scathing GAO report in 1990 found that the NIH wasn't implementing its own policy. Women were being excluded from a number of large federally funded clinical trials. Among them was the physician's health study of 22,000 male doctors that demonstrated the benefit of aspirin in preventing heart disease, but contributed to years of misdiagnosis and underdiagnosis of heart disease in women. Rather than calling NIH leaders to the Hill for your typical hearing, Senator Mikulski, along with Congresswoman Pat Schroeder, Olympia Snowe, and Connie Morello, were so frustrated that they got in a car and actually drove up to the campus, the NIH campus in Bethesda, to take the center directors to task. It says a lot about the patience and passion and impatience of the women that they took this step. And as Carolee noted, this was a bipartisan group. And I think this is a key point, that bipartisanship was a big theme around these important changes to women's health policy at the federal level. And also around the same time, President George Bush appointed Dr. Bernadine Healy, a noted cardiologist who had served in various high-level positions in the federal government, as the first and to this day only woman to lead NIH. So the women needed a vehicle. They had been working through the Congressional Caucus on Women's Issues. They had introduced something called the Women's Health Equity Act, but they really needed a must-pass vehicle to get the changes, including the requirement that women and minorities be included in clinical trials, to get that into statute. So the NIH reauthorization formed the perfect vehicle. The NIH needed to be reauthorized. And in 1990, Senator Mikulski introduced the NIH Revitalization Act. So in addition to requiring clinical researchers to include women and minorities in trials, and I want to note there were some exemptions, but the law was very clear that cost alone would not exempt researchers from the requirement. The same legislation also wrote into the law books the NIH Office of Research on Women's Health, which had been established by the NIH several years earlier. And Dr. Clayton will be discussing that in more detail. The act also included a requirement that NIH establish intramural clinical research programs in obstetrics and gynecology, because the lack of those professions at NIH was deeply disturbing to the women members. And it also included increases for breast cancer and osteoporosis research. Finally, in 1993, the NIH Revitalization Act was signed into law by President Clinton. So let's hear from Senator Mikulski and Congresswoman Pat Schroeder.
The Public Health Task Force report showed that women were being systematically excluded from scientifically appropriate research protocols.
We were all horrified a couple years ago when we found that medical journals all defined the norm as a 180-pound male. That meant we were all abnormal.
And then that led to NIH including women in clinical trials. But it wasn't mandated. In 1990, we wanted to see how it was going. So the congresswomen commissioned a report from the government accounting office. We saw that women were absolutely being excluded, that the encouragement had taken us in very little direction. An example would be this famous study, take an aspirin a day, keep a heart attack away. Not one woman was included in it, and yet the leading killer of women is heart disease. When I heard that, I was furious. We said, this is not science, this is bias, and we want it changed.
There was another very important march that Connie Morello was with Senator Mikulski and I when we marched on NIH.
I think it's time we do something, and we have to show we're more than photo ops, geo studies, and I think we ought to go out to NIH, get all of those directors in the Institute, get them around a table, and ask them what are their goals and timetables for including us in the research.
Rather than holding just one more meeting where we could be brushed off, we went out to NIH on a crisp fall day in 1990. Pat Schroeder, Congresswoman Morella, Congresswoman Olympia Snowe.
I only wish you could have all been in the room with us when the head of the Aging Institute explained to us that there were no women in the aging study, that all 75,000 were men, because it was easier to use the men's room for the tests.
We didn't want to be invisible anymore, and we didn't want our needs to be invisible, and we didn't want the needs of the American women to stay invisible. We didn't want to tell the science what to do. We wanted them to tell us what they were going to do to come into the 21st century. And as we pressed, NIH announced that they would be establishing internally the Office of Research on Women's Health, an internal office to begin to move beyond encouragement into reality of including women where scientifically appropriate in medical protocols.
Well, there you have it. There's nothing like hearing it directly from those incredible women who were involved at the time. I'm going to turn it back to Carol Lee, and I'm happy to answer questions as the panel moves forward. Thank you.
Thank you, Jenny. It gives me goosebumps to watch that video and know that determined, feisty, powerful group of women really did take it upon themselves to make this happen. And I stand on their shoulders. I think we all do. I'm a little bit speechless, but I think let me move it to Janine. And thank you, Janine, for all the great work you're doing in keeping the Office for Research on Women's Health moving forward. I believe it was founded in 1990 is what I found, and you can talk a little bit more about that. And of course, Dr. Vivian Penn has led it brilliantly for a number of years, and now you have taken it on with huge determination and energy, for which we're also very grateful. So let me ask you, how is the office different, in your opinion, today than when it was first formed? And tell us a little bit about the history.
Thank you, Carol Lee, and thank you to WHAM for the opportunity to participate today. I admire and appreciate your leadership, as well as WHAM's efforts to advance women's health research and improve the health of women. I'm delighted that we're celebrating the passage of the Revitalization Act, and I went back to look at it, preparing for today, and it has a subtitle. The subtitle is Clinical Research Equity Regarding Women and Minorities. 30 years ago, that was the subtitle. And the story of ORWH and women's health research actually begins before the Act and before the 1990s. And you mentioned that we stand on the shoulders of giants, and I feel that as well. During the 1960s, civil rights and women's rights advocates began to draw attention to inequities that we saw in our society. Inequities inherent in biomedical research, as you heard from Senator Mikulski, bias in the healthcare system, and that resulted in gaps in knowledge and what we actually knew about how diseases affect women and what we need to do to treat them. And so from that rose the women's health movement. And I think that word is really important in this story. You saw those women in that video. They are movers and shakers, and it was women everywhere that were part of the women's health movement and across the board, and talking about different women too, African-American women as well, organized around the Black women's health imperative and others. And it was these efforts, these movements that drew the attention of a wide range of other giants that we stand on the shoulders of. And the Assistant Secretary of Health back in the 80s, Dr. Edward Brandt, established a task force, the Public Health Service Task Force on Women's Health Issues. You heard Senator Mikulski refer to the task force findings. The chair of that task force was Dr. Ruth Kirstein, the first woman to direct an institute at NIH, the National Institute of General Medical Sciences. And she pointed out through that task force's work that we need a greater inclusion of women in NIH-funded clinical research, and recommended that we need to do research on the ways diseases show up in women. And that bicameral, bipartisan Congressional Caucus for Women's Issues weighed in forcefully, calling for greater inclusion of women in federally funded research. And in response, the NIH did recreate the Office of Research on Women's Health, and the first full-time director, Dr. Vivian Pinn, was appointed, another giant of biomedical research. And she led those early years establishing programs to expand women's health research, making sure women were included in NIH-supported studies and advance women in science careers. And then 3 years later, the Revitalization Act was signed into law. And so now the Office of Research on Women's Health was established in statute. And in that statute, which is 30 years ago, very prescient in its language, required inclusion of women and underrepresented racial and ethnic groups in NIH-supported clinical research, required NIH to address across the 27 institutes and centers women's health across the board, not just in reproductive issues, but across the board, across the life course, called out menopause. Menopause is in that statute, talked about the importance of multidisciplinary approaches and how critical it was to advance women in science careers. So 30 years ago, this was all laid out, what needed to happen, and that it was going to be required going forward to include women in that research. So you asked about how ORWH has changed over the years and what the Act's relevance is to today's health challenges. And I feel privileged to be in this seat, to be able to continue to lead and stand on the shoulders of so many giants. The mission remains unchanged, but we've transformed our approaches to women's health, and we've taken on ambitious initiatives to carry out that statutory mission, which we take very seriously on behalf of the American people. So let me start with the former. Perhaps one of our greatest achievements, and we haven't done this alone, this is the entire community, is to make sure that everyone understands that women's health is everything that affects a woman from head to toe, inside and out, across her entire life course, beyond maternal and reproductive health. A broader, holistic, multidimensional conceptualization of women's health has been advanced because of some of the work that ORWH has done in terms of working across the institutes and centers and our programming. And then through our signature programs, we have supported the advancement of women's health researchers, both men and women, who are focusing on women's health in our BIRCH program, building interdisciplinary research careers in women's health. We've expanded the cadre of people that do that research. And it's a very successful program. We also created a program on sex differences in disease called our SCORE program. And so now we better understand what the bases are for those sex differences you see. And then over the years, as things have changed, we've had other acts, other legislation, most recently the 21st Century Cures Act, that built upon some of the changes put forward in 1993 and expanded the scope of inclusion of individuals in clinical research. And now pregnant and lactating people must be included. Individuals of all ages, from the youngest young to the oldest old, must be included unless there's a scientific reason not to do so. As a result of the 21st Century Cures Act, each and every one of the 27 institutes and centers have to include a women's health research priority in their strategic plans. Their institute directors meet with me yearly to talk about their plans for women's health research, So I have an opportunity to help better coordinate across NIH at the highest levels. And here's what I really want to make sure our viewers hear about. Applicable phase 3 clinical trials funded by NIH have to have their results by sex and or gender, race and ethnicity put into clinicaltrials.gov so that the public can have that information, healthcare providers can have that sex disaggregated data to be able to inform and improve the health of women in their treatment decisions. So again, one of the things that we have been able to do is kind of do the clarion call for issues. We bring attention to important issues, and maternal health is one of those. As you know, in our country, we have one of the highest rates of maternal mortality in high-income countries, and unfortunately, our rate is increasing. So we have created programs to converge on that problem and address it from multiple vantage points. The Improve project is just one of those. We've also addressed the fact that all women are not the same, and underrepresented, underreported, and understudied populations of women, we call U3 populations, need specific attention. And we call attention to the fact that the social determinants of health do affect health of women and access and quality of care. Our newest program is called Compass. And lastly, we've focused on the careers issue, and we've sought new and innovative ways to support women in science careers, whether it's providing childcare costs for NRSA fellows. We established a gender equity prize so we could reward institutions who were doing a good job and disseminate that information. And we studied factors that affect women advancing in biomedical careers, not to study them, but to disseminate the ones that work, so that we can get the word out about lessons learned. And when COVID hit, we mobilized to be able to provide what we call continuity supplements, funding for researchers who could not do their research because of critical qualifying life events, death of a spouse, pregnancy, childbirth, severe illness of a spouse. All of those qualify as critical life events. So we provide additional funding to make sure that research keeps going and that researcher can continue as well. And that's because we know that there is a diversity dividend from women participating in biomedical research. And that means greater productivity, greater innovation. Women are also more likely to study women's health. And believe this, Carol Lee and our viewers, women are more likely to report results disaggregated by sex, regardless of the topic under study. And then finally, I'm really proud that ORWH was the leader in developing the 2016 NIH policy on advancing sex as a biological variable, requiring investigators in preclinical animal work and clinical work to account for sex as a biological variable, announcing our expectation that the default is to study both sexes unless there's a scientific reason not to do so. So we still have gaps in knowledge, we still have a ways to go, but that policy has changed the way we are doing science today. And it's led to breakthroughs in a number of areas, for example, cardiovascular disease and cancer. And so a final word about women's health research and the multiplier effect that you get. As WHAM reports have shown, there's a tremendous economic upside to investing in research on diseases and conditions that affect women. So there's social and cultural benefits as well, societal benefits. And these benefits taken together show that we are all better off in so many ways if women are healthy. Women play central roles in society as leaders, as healthcare decision makers, as mothers, as caregivers, as essential workers. And their health and well-being are central to the health and well-being of families, communities, and society. So when a woman is healthy, a mother is healthy, a caregiver is healthy, a CEO is healthy, a healthcare decision maker is healthy, a leader is healthy. And if we can keep women healthy, we can keep society healthy. So everyone will benefit. Back to you, Carol Lee.
Oh my goodness, fantastic. And thank you so much for your leadership, your passion, your determination. It has been such a pleasure to get to know you and to partner with you. And I really look forward to a lot more. I'm going to come back with some questions for you, Janine, but I'm going to skip to Marjorie right now and ask her really, or say at least introduce you, Marjorie, in the sense that In 2015, you were invited to the U.S. FDA Office of Women's Health, and you led and disseminated research, education, and health policy initiatives across the agency and other federal and academic environments. And so I guess I'm kind of curious how the passing of this act affected the teaching, training, and practice of medicine then. And of course, what you're feeling now, since you are now very much leading a medical institution.
Yes. So, when Carolee, thank you for inviting me to be on this panel. I think the 1993 resolution and all that came after that really paved the way for where we are today in sex and gender science and in patient care. When I was invited to go to the FDA, I thought it would be 1 year. It ended up being 4 years. It was a remarkable time. I learned that the federal agencies, we have offices of women's health at FDA, at CDC, at HRSA. They work together. They, collaborate on major issues. And I left with a really healthy respect for our public servants that work in the federal landscape. I also wanted to go behind the curtain to just kind of see why we weren't getting some of the data or some of the labeling. How did FDA really make decisions? And I had some, several aha moments during my 4 years there. And but FDA made great strides as well, with changes in labeling and also with the drug trial snapshots, which you can go and see who is actually enrolled in trials. But I also found some things that were, still need some work. We still have work to do. We have a paucity of underrepresented populations in clinical trials. The FDA doesn't have the authority to mandate the number of underrepresented populations or women who will participate in clinical trials. Congress has not given them that authority. And so we still need to do a lot of advocacy. We can't slow down in the advocacy work on the Hill because we need them to know that FDA does need more authority. NIH does need more resources in order to close those knowledge gaps. So I came onto the scene probably in sex and gender medicine in 2001. And the signature event for me was Marianne Legato's book, Gender Specific Medicine, which is a 900-page tome of sex and gender differences in science. And that was in the early 2000s. And that really paved the way for my career. And really, as a scientist and a clinician, I wanted to understand where this science was, because there were a lot of myths out there about women. Women complain more at their visits. Women have complain about more side effects. Women won't participate in clinical trials. And so we've had to be, I think the generation that came after those that enacted the 1993 resolution, I think we have been constantly trying to be myth busters. Female animals are data is no more scattered than male animal data. Women will participate in clinical trials if they're asked. And so a lot of what we're doing now, and I really respect what WHAM is doing, is bringing this science to light so people know that this isn't just intuitively we think this is really what we know. And one thing that was on my bucket list as a career person in sex and gender medicine was actually to have a textbook out there for practitioners. And because of all the work of the 80s and 90s and the work that's gone on since 1993, we were able to bring this book to fruition. And this is for primary care doctors. And this is practice. This is applied science. This is that amazing work that NIH is doing, that FDA is doing, that academicians are doing. And finally, as many of you know, I'm very much a proponent of the fact that research cannot save lives unless it is taught to a clinician or a provider. It will not get to the patient any other way. And so we need to make sure that our medical schools, our pharmacy schools, and nursing schools are not teaching one-sex medicine, gender blind care. And unfortunately, that is a hidden curricular agenda where we are not calling that out in medical schools. So as a dean of a medical school now, I can say that I brought some of this to the forefront and with our healthcare delivery system, where I'm a chief academic officer, and really am starting to make headway within the school and within the healthcare system about how they're reporting their data, how we're teaching our students, how we are implicitly biasing future doctors to think that the 70-kilogram male is the norm. So there has been so much progress. I would not have a career that I love so much without I stand on the shoulders of all of those strong women that made this happen. But I'll stop there, Carolee.
Well, I'm in such great awe of all that you've done. I like Janine and Hadine and Jenny. I have just so much enjoyed getting to know you from the past couple of years, where you've been so incredibly helpful to helping me launch WHAM. And to the work that you're now doing, which obviously is utilizing so much of the skills that you acquired at FDA and in your earlier career. So again, congratulations to you as well for the incredible leadership and the impact that you're making. I'm going to come back with more questions as soon as we get Hadine, and thanks so much, Marjorie. It's great to hear the great success you're having. Hadine, as WHAM's chief scientific partner, we are, as you know, so grateful for your ongoing wisdom and guidance in helping us steer WHAM on the right path. Share with us a little bit, because you now run a different kind of center, which is the Connor Center. A different kind, not necessarily what Janine and Marjorie are doing. Talk to us a little bit about the Connor Center. Why was it created? What role does it play locally and national? And in your, I guess, opinion, what are the synergies between academic research and policy activities?
Of course, such a pleasure to be part of this panel and to work with you, Carolee, over these years. And appreciate all your leadership, bringing us together across all these disciplines. I will say, I'm really in a privileged place in that I lead a comprehensive research center across all areas of medicine at Brigham and Women's Hospital, Harvard Medical School. So we are a research group that stimulates science across all areas. We're agnostic to the specific disease area, and most of the work is outside of gynecology and reproductive medicine, but of course includes that. So what are we? The Centers of Excellence were sponsored by the NIH in the late 1990s. There were about 20 centers sponsored. And Harvard was one of them. And the Harvard one was based where I am at one of our three major teaching hospitals, Brigham and Women's Hospital. And at the time, it was a new concept that, across all these different hospitals and medical centers, there would be comprehensive, multidisciplinary organization towards primary care of women out across the lifespan, including and beyond reproductive and maternal care. And so Harvard was one of these centers that was funded. And when the funding left, because there was not sufficient funds to continue these centers, there was a call to action to local resources and researchers to engage and ensure that there was continuation of these centers. Many of the centers across the country were not able to continue because there wasn't the local investment. And I'm really so grateful because we had both a huge institutional priority and commitment, and also a major benefactor, Jack Connors, who named the center in his mother's name, Mary Horgan Connors, who invested in the center and endowed it in the early 2000s. And, why was Harvard picked and why did this happen? We have a lot of excellence in research leading the Nurses' Health Study, one of the major sites for the Women's Health Initiative, many other activities that were including and beyond reproductive and maternal care. And so we had like a critical mass. And I think part of why we've been so successful is that we do have critical mass. We've been able to stimulate that. And one of my major commitments is to continue to stimulate that with some of our programs. So we do include a number of programs, and the center has evolved a little bit. It was initially led by an endocrinologist, Andrea Juneff, and then a cardiologist, Paula Johnson, who really grew it into a major clinical program and policy program. And then when I took over now about 6 years ago, we grew the research arm, and that's where our major focus has been. And one of our major goals is to make sure there is the next generation. We have a large early career program to stimulate and give pilot awards to new people coming up who want to study whatever the disease, kidney disease, lung disease, et cetera. And in terms of sex differences, sex-informed, gender-informed approaches. And so we have a large program in that way. Our other major research programs fall into two thematic areas. One is called First in Women, the notion that when we have new treatments being developed, which are usually come out of ideas in academic medicine and research, that we ensure that there's sex and gender understanding as these new therapies are developed. So we're very focused on making sure that as drugs, devices, digital approaches are developed, we have sex-specific information and knowledge, and we fund research in that capacity. And we partner externally with a range of organizations, foundations, including biopharma organizations, to ensure that this lens is incorporated throughout. The other major area is called our stress in women's health, trying to make sure that we always understand how the stress exposures that women have, which are different than men's, and although overlapping, how that affects the health of women. And it's under that umbrella pillar that we have what Dr. Clayton referred to, one of these NIH centers of excellence called the SCORE, a research group. We also have other training programs that Dr. Clayton mentioned, the Birch, and also a WERHR. So we have a lot of different junior investigator programs. And right now we're working on a large community engagement program to stimulate and engage women across the local communities who are underrepresented. So that's a lot of activity that we do. I'm also extremely proud of people who are in our center, Dr. Deb Bartz, Dr. Joanne Manson, and others, who led the first ever Harvard Medical School course on the health of women, sex and gender informed medicine. And what's unique about this is that it's teaching medical students based on research data, because what we're trying to do is ensure that the data are there to support the argument that this is important. And you heard it from Dr. Barbara Mikulski and others. We want to be included and we want the data. And we need to make sure that the data are there. And of course, as Dr. Jenkins said, we need to make sure that this is taught at all levels, starting right from the beginning with medical students. So those are some of our major activities, and we are still leading nationally because of some of this really comprehensive work that we do. We support about 10 to 12 people doing new investigators in this field every year to make sure the pipeline is stimulated, as well as major senior investigators who do this work. And we have partnered, as you asked, about policy approaches and where the synergy is. So we have a policy arm. The policy takes on a range of forms and advocacy. So one of them is publishing and communicating about how the science and the work that we do should inform how healthcare is designed, or what is financed and resourced, or what should be prioritized for investigation. And we have had Our policy arm is led by Dr. Lydia Pace, who does a lot of that work. We've also had people who historically have been involved on the Hill in advocating for, say, lung cancer research for women, which at the time had been understudied and still deserves major study. So there's been a number of different ways we intersect, we contribute to policy, and I think I see us more now as being an empiric data source of, of really highly vetted science that we can partner with major policy initiatives like yourself and WHAM and others to take this work forward and ensure that it is translated in such a way that it impacts design of care, priorities for funding, and other regulatory approaches. So we're very concerned about ensuring that everything we do translates to therapeutics, translates to education and clinical care. We have a large clinical multidisciplinary center within our hospital. So we're always thrilled to partner. This is a major undertaking of so many people involved on so many fronts. And it's really a pleasure and privilege to be part of all these initiatives. So.
Well, thank you, Hadine. And you know that the feeling is mutual. We have enjoyed tremendously the support that you've offered to us. It means the world to us. So part of WHAM's role really is to support not only past leadership, to acknowledge past leadership, but to support, as you're seeing, the current wonderful leadership that exists. And how will we do that? And how can we be more forceful in what we're doing? And so WHAM will be launching a very robust social media campaign, #3not30, during the coming year to focus on what needs to be achieved in the next 3 years, not another 30. How can we make significant change happen? And I think I'd like to turn to my panelists and ask them what 3not30 might mean to each of them. What kinds of changes should we aspire to make in 3 years? And so let me go to you, Jenny, and say, where are you today in terms of where is Research? Research America is certainly a leader. And if you could create significant change in 3 years, what might that look like?
We need to come so far in terms of racial inclusion in clinical trials. We've made a lot of progress on the gender front in clinical trials, not preclinical, as Dr. Clayton noted. We still have to do more around sex as a biological variable in bench science, but in clinical trials, we are really woefully behind in terms of racial and ethnic diversity. So, and that includes women of color. So there is a gender angle to that as well. So I think that is a critical priority.
Thank you. Janine, would you want to take that on?
Sure. I think that to me, 3not30 means that we learn the lessons that the pandemic has taught us. Our lives depended on learning, working together, and adapting in the pandemic. And we've shown that we can work together across sectors if our lives depend on it. And that means that we should be able to build on those foundations of partnerships that we've created, because the lives of women do depend on us just doing that. So we, for example, in the pandemic, because we had the basic science that worked on the mRNA vaccines, we were able to move that forward. That would have not happened without that firm foundation. And so we now know, because of so many people's work, so many investigators, so many advocates, so many community leaders, so many scientists and clinicians, that sex matters at every level. And we need to think about that from the outset, not at the end as an afterthought, right? So our mindset, from the outset, we need to design that. And I think to do that, to solve the unsolved health challenges, we need that same sense of urgency that we have shown that we can, maybe not at the exact same speed, but the same sense of urgency. But we need to accelerate, right? That 3not30 is about acceleration. And from my perspective, from research, we want to go faster from investigation to impact, right? And that means that we need to have the right engine design, the right fuel for where we're trying to go, and the right partners. So harnessing the power of partnership, we've shown that we can do it. You know, we just need to supercharge those partnerships for the next level and put women at the center of the world in terms of this is where we're focusing to move forward, because we know this is the right thing to do, a smart investment, and will benefit everyone. So we have to work across disciplines. That's the other thing, right? And that means we have to incentivize as an ecosystem ways to work together instead of parallel pathways, right? And we need to converge together. And so in incentive structures that make that easier will allow us to move from silos to synergy in what I call synergistic science. So looking forward to centering women, centering the needs of women, centering research questions and designs that address those needs, and bringing in more partners so that women and sex differences and SABV and sex and gender are at the forefront of every decision being made that has something to do with human health.
Well done. I hope WHAM plays a role.
Sorry, Caroline.
No, go ahead, Hadine.
I just want to add to something that Dr. Clayton just said, because I think she made a number of really important points. And one of them, you know, if I were to say, you know, what would I want to see in 3 years is a change in mindset. And this notion that sex and gender informed, not differences, but informed understanding of therapeutics and disease diagnostics is foundational in everything we do, that it's not an afterthought, that it's not something we have to retrospectively justify or analyze or segment in our data. In the same way we do that with children and older people, we haven't done that for sex and gender informed approaches. And there's a question about this in the Q&A that I see, which is somebody as a toxicologist mentions this, you know, we don't always have data right from the beginning, the toxicology data, which is, you know, side effects, and we don't always ensure that we understand some of this early on in the animal models, in the human models, before we then start using these treatments in larger trials. So because it's not foundational, and we don't do that with children. Again, we don't do that with children. And so it has to be a mindset shift that leads to an expectation that this is incorporated at every level.
It's a great observation. Thank you for that. Marjorie, 3 not 30.
Yes, definitely. I agree with all of the other panelists. I would say that when great things and changes happen in this world, usually women are the ones rising up to help create those changes. So, you know, I have daughters in the millennial and Gen Z generations. We have some really interesting conversations about what they're seeing happen. And so I think that we need to continue to activate the population around the importance of this. I would also say there's low-hanging fruit. I do think that the FDA needs to be given more authority by Congress to help design clinical trials, which to help the pharmaceutical companies to include women. We have made great strides in women's participation in clinical trials, but we're still just counting them. We tout 60% or 50%, but we're not disaggregating the data. We're not even doing post-hoc analysis to look for signals to help create that next research project that would help answer that question. And I think that I'm really pleased and happy that women are participating at record numbers in clinical trials, but I would love to see the outcomes reported. And I think every journal should require that. I think every journal should require that it's reported if they do not do that. And I just think we're here at 30 years and we're still counting, Carolee. And what we really need to do with 3 not 30 is make it count.
Well, we totally agree. And of course, that is one of the initiatives that we're trying to make happen with your support. 3 not 30 is definitely our call to action, and it's because we believe that collectively we have the economic power to create change. So we at WHAM, as you know, because you've heard me say this, recognize that women drive the economy. And that is why we did a study and commissioned the RAND Corporation to understand what would happen if we were to accelerate women's health research. And for many of you, you know what the response to that has been, which was extraordinary. So a small investment, basically doubling that budget of $350 million allocated to our areas of study showed a $14 billion return. So those numbers and all of that data is on the whamreport.org. But I think more importantly, women drive the economy. We make up more than 50% of the workforce. We're 52% of the population, 60% of the wealth in the country. We're responsible for 85% of the spending and 80% of the healthcare decisions. So it's up to us, I think, all women, to create, like you said, Marjorie, the changes that we set forth today so that women and society flourish in 3 years, not 30. And that is obviously one of our goals, and one of the reasons that we're so passionate about working with all of you, because we can't all be just talking in our own tunnels or in our own echo chambers. I think we need to really be building much larger consortiums and coalitions with economists, advocacy groups, business, and the investment community, which we're very interested in. If you look at investment in women businesses focused on women's health, it's less than 1% in biopharma. Women across the board receive less than 3% of VC capital. All of that needs to change. We recognize the obstacles that there are. I want to come back to some of the questions, though, because I think we'll all figure out ways that we can drive some of this, but I think one of the things that we also need to do is motivate the next generation. And that is one of the questions. How will we motivate others, including men? How will we motivate the next generation to take this on? Because none of us have the patience to wait 30 years. And that is the message. How are we going to motivate others to either enter into the workforce in terms of research, become researchers? You talk about medical schools, Marjorie, and teaching in the medical schools. Obviously, you're making a great impact at where you are in South Carolina. How do you nationalize that? How do you internationalize that? How do you spread that so that it isn't localized?
So we have built a coalition nationally through a Sex and Gender Medical Education Summit. It's now multidisciplinary. Hundreds of nurses, physicians, pharmacists come together to talk about innovative ways to integrate sex and gender into the curricula. I do think that, Carol Lee, when you came to the forefront and I came to the first WHAM meeting, I was so thrilled to see someone, a leader like yourself, a visionary thinker, helping us to move this out of academics and out of the federal landscape and expanding it out. And when you talk about motivating, how do we motivate people? We motivate people by making it real to them. So sex and gender, being informed about your health, it matters to men as well. It matters to boys. So by making it matter to them, not just, oh, you have women in your life you love and want them to be healthier, but this also matters to you because of this, then I think that, I think that's when we'll see people starting to become more interested, when we make it pertinent to their life and their daily living and to receiving the highest quality healthcare they can get.
Janine, do you want to take that on as well in terms of some of the word that you're spreading and the work that you're doing?
Sure. We on our end, because I'm in the research lane, we're supporting the researchers and the next generation of researchers by creating curriculum in collaboration with the Office of Women's Health at the FDA, both at the introductory level, and I worked with MJ on that in the past, and I'm pleased to work with the current director now on that, so that we make those tools available and teaching at different clinical research courses at NIH that meet reach hundreds of countries, literally hundreds of countries of students. So changing that next generation by making that information freely available is one of the spaces that we occupy. But I do think that to the point of the ecosystem, and I agree with MJ, these are system-wide issues that need multiple stakeholders to solve. And journal editors, publishers, venture capitalists, philanthropists, everyone in the healthcare arena has a role to play here. And making it matter means different things to different people. So putting incentives, both carrots and sticks, in those systems, checkpoints, to guide efforts towards the way that we know that they can benefit people is one strategy. And then sharing information. We've been pleased to share with other countries our experience with SABB, and other countries like Canada have shared their experiences with policy change as well.
Well, I can't thank you all enough for your wisdom, for your encouragement, for your support, for your passion, and for being collaborators with WHAM. It is really, it has been such an honor and pleasure to work with you all. And I think this is just the beginning. So it will take an impassioned group of women, just like it did 30 years ago. This is part of that group. The WHAM Collaborative, which you can learn more about on whamnow.org, consists of many more who are also doing research and or in some way involved in women's health. And for more information, we certainly would send you to whamnow.org or follow us on social media. And we thank you all for joining us today and thank the incredible panel. I look forward to seeing you at our next dialogue in the series, which is on February 9th and which will focus on women's heart health. And until then, thank you all for your great support, your interest, and your enthusiasm. Take care.